thorax. Learning objectives are that at the end of the lecture, the student should be able to describe the superior and inferior aperture of the thorax, its boundaries and contents, describe the thoraco-abdominal diaphragm in detail, and describe the respiratory movements. Now, thorax, or Latin chest, forms the upper part of the trunk of the body. It is not only permitting the boarding and lodging of the thoracic viscera, but also provides the necessary shelter to some of the abdominal viscera as well. Now, the trunk of the body is divided by the diaphragm into an upper part called the thorax and a lower part called the abdomen. Now, the thorax is supported by a skeletal framework called the thoracic cage. The thoracic cavity contains the principal organs of respiration, that is the lungs, and of circulation, that is the heart, both of which are vital for life. Coming to the superior aperture or the inlet of the thorax, the narrow upper end of the thorax is continuous with the neck and is called the inlet of the thorax. It is kidney shaped, transverse diameter about 10 to 12.5 centimeter, and the anterior posterior diameter is about 5 centimeter. Boundaries: anteriorly, upper border of the manubrium sterni; posteriorly, the superior surface of the body of the first thoracic vertebra, and on each side the first rib with its cartilage. Here, the plane of the inlet is directed downwards, as you can see, forwards, and with an obliquity of about 45 degrees over here. Right? The anterior part of the inlet lies about 3.5 centimeter below the posterior part, so that the upper border of the manubrium sterni lies at the level of the upper border of the third thoracic vertebra over here. Right? Partition at the inlet of the thorax. The partition is in two halves, the right and left, and there is a cleft in the middle. Each half is covered by a fascia called the Simpson's fascia, or the suprapleural membrane. It is separating the thorax from the neck, and this is roughly triangular in shape. Now, the apex of this membrane is attached to the tip of the transverse process of the seventh cervical vertebra and the base to the inner border of the first rib and its cartilage. Morphologically, the Simpson's fascia of the suprapleural membrane is regarded as the flattened tendon of the scalenus minimus, or the pluralis muscle. Thus, it is formed by the scalenus medius and the endothoracic fascia. Functionally, it is providing rigidity to the thoracic inlet. Also, to the root of the neck is not puffed up and down during respiration. Now, the inferior surface of the membrane is fused with the cervical pleura over here, beneath which lies the apex of the lung. Here, this is the suprapleural membrane, the superior surface related to the subclavian vessels and other structures at the root of the neck. Now, structures passing through the inlet of the thorax. Firstly, the viscera. We have the trachea, esophagus, apices of the lungs with the pleura, and the remains of the thymus glands. These were the viscera. Coming to the large vessels, we have the brachiocephalic artery on the right side, right? This is the brachiocephalic artery. Then we have the left common carotid. Okay. On the left side, right and left brachiocephalic veins. The smaller vessels, we have the right and left internal thoracic arteries, the right and left superior intercostal arteries, the right and left posterior intercostal veins, and the inferior thyroid veins. The nerves related to the inlet, We have the right and the left phrenic nerves, right and left vagus, right and left sympathetic trunk, and right and left first thoracic nerves as they are ascending across the first rib to join the brachial plexus. Now, structures passing to the inlet of the thorax, the muscles, we have the sternohyoid from the sternum to the hyoid bone, the sternothyroid as seen over here from the sternum to the thyroid cartilage, and the longus colli muscle. Now, so what is the cervical rib? Basically, it is a anomalous rib attached to C7 vertebra. Okay, not normally present, occurring in only 0.5% of the subjects. Now, such a rib can cause traction on the lower trunk of the brachial plexus, which is arching over the cervical rib. Now, in this case, the person may complain of paresthesia or abnormal sensations along the ulnar border of the forearm, wasting of small muscles of the hand supplied by the segment T1. Vascular changes may also occur. In coarctation or narrowing of the aorta, the posterior intercostal arteries are greatly enlarged and they provide a collateral circulation. Pressure of the enlarged arteries produce a characteristic notching of the ribs, especially in the posterior parts. Now, what is the thoracic inlet syndrome? There are two structures arching over the first rib, that is the subclavian artery and the first thoracic nerve. These structures may be pulled or pressed by the cervical rib or by variation in the insertion of the scalenus anterior, and the symptoms may therefore be vascular, neural, or both. Coming to the inferior aperture or the outlet of the thorax, the inferior aperture is the broad end of the thorax which surrounds the upper part of the abdominal cavity and is separated from it by the diaphragm. You can see it's the diaphragm. Boundaries are: anteriorly we have the infrasternal angle between the two costal margins. Posteriorly, the inferior surface of the body of the 12th thoracic vertebra over here. And on each side we have the costal margin formed by the cartilages of 7th to 12th rib. Diaphragm at the outlet of the thorax. It is closed by this large musculo-tendinous diaphragm partition, which is called the diaphragm. In fact, it is the thoracoabdominal diaphragm, which is separating the thorax from the abdomen. Now, the structures passing through the diaphragm. Now, there are three large and several small openings in the diaphragm, which allow passage of structures from thorax to the abdomen or vice versa. Now, the large openings, we have the vena cava opening in the central tendon, the esophageal opening in the right crux of the diaphragm, and aortic opening behind the median arcuate ligament. The small openings are the superior epigastric artery passes in the space of Larry present between the slip of xiphoid process and the 7th costal cartilage slip of the diaphragm. When this foramen is enlarged, it is called the foramina Morgagni, and the musculophrenic artery perforates the diaphragm at the level of the 9th costal cartilage. Now, lower 5 intercostal vessels and nerves pass between the costal origin of the diaphragm and the transverse abdominis. The subcostal vessels and nerves pass behind the lateral arcuate ligament. Sympathetic trunk, we can see this is the sympathetic trunk passing behind the medial arcuate ligament. The greater and the lesser splanchnic nerves pierce each crux of the diaphragm. You can see this is the greater splanchnic nerve piercing the crux of the diaphragm, and the left phrenic nerve piercing the left cupola. Now, the caval opening we saw previously. It is situated at the 8th level in the right part of the central tendon, obviously. Shape is quadrilateral. The structures passing are the inferior vena cava, the right phrenic nerve, and the lymphatics of the liver. Now, when the diaphragm contracts, the vena caval opening dilates. The esophageal opening is present at T10 and the splitting of the right crux. The shape is elliptical. The esophagus, both the vagal trunks and the left gastric vessels pass through it, and the effect of contraction is the constriction of the esophagus. Aortic opening lies at T12 behind the median arcuate ligament. The shape is rounded, and the structures passing are the ATA structure, that is the aorta, the thoracic duct, and the ascending vein. There is no effect on this opening by the contraction of thoracoabdominal esophagus. What are the respiratory movements? The lungs are expanding during inspiration and retracting during the expiration. Right. Next, the movements are governed by the following factors. Alteration in the capacity of the thorax brought about by movement of the thoracic wall. Increase in volume of the thoracic cavity causes a negative pressure, intrathoracic negative pressure, which is sucking in the air onto the lungs. Now, movement of the thoracic wall is chiefly occurring at the costovertebral joint and the manubriosternal joint. Okay, costovertebral and manubriosternal joint. Elastic recoil of the pulmonary alveoli and that of the thoracic wall expels air from the lungs during the expiration. Principles of movement. Each rib can be regarded as a lever, the fulcrum of which lies just lateral to the tubercle. Because of the disproportionate length of the two arms of the lever, the slight movements at the vertebral end of the rib are greatly magnified at its anterior end. The anterior end of the rib, you can see, is lower than the posterior end. Therefore, during elevation of the rib, the anterior end also moves forwards. This is basically occurring at the vertebrosternal ribs, the main ribs over here. Along with the up and down movements of the second to the sixth ribs, the body of the sternum also moves up and down. Okay? Body of the sternum also moving up and down, and this is called the pump handle movement. In this way, the anterior posterior diameter of the thorax is increased. Now, have a look at the pump handle and the bucket handle motion. So this is the thorax and the ribs. So the upper ribs, okay, and the lower 8 and 9 ribs. We have the manubrium over here, the sternum, okay, and then we have the costocartilages. Now, This is the anterior part. This is the manubrium sterni. Okay, it is placed like this. Then you can see this is the horizontal movement. Now, movement at the upper ribs pushes the sternum anteriorly and superiorly. Sternum, you can see over here, it is pushed. Movement occurring at manubrium sternal joint, it is pushed anteriorly and superiorly. Okay, anteriorly and superiorly, like the increasing the anterior posterior diameter. This is the pump handle movement. You can see the sternum, it is going anteriorly and forward. Okay, and see the pump handle motion. Now, the middle of the shaft of the rib lies at the lower level than the plane passing through the two ends. Therefore, during elevation of the rib, the shaft is also moving outwards. Okay, you can see when the ribs are moving outwards like this bucket handle, it is causing an increase in the transverse diameter of the thorax. These movements are occurring at the vertebrochondral ribs, okay, and therefore are called the bucket handle movement. So just have a look at this. We have the lower ribs over here and they are moving out laterally. Okay. Observe the movement of the lower rib. Yeah, you can see they are moving outwards. They have a more angular shape with an indirect attachment to the sternum, resembling a bucket handle. Indirect attachment and the angular shape, it is causing more motion in the lateral aspect. Here you can see, here it is. The lower ribs upward rotation in elevation, and here we have the increasing in the transverse diameter by the movement of the lower ribs. Okay, so this movement is called the bucket handle movement, increasing the transverse diameter of the thorax.